recording. Cool. Okay. So just before I start, I'll just tell you who I am, and then we're going to go straight into the guidance. So I'm Nicky Woods, and everything I do is around midlife wellness, well-being, menopause. I have kind of two strands to what I do. One is I work with businesses to help them understand menopause better. So I train managers. My background actually before doing this was HR. And then the other side is I work individually with women to help them have a better midlife, basically. So that's, losing fat potentially, getting fitter, having better relationship with food, and navigating obviously the perimenopause and menopause experience. And I'm also the author of a book on menopause, The Man's Guide to Menopause, because I felt like everything that I was doing, well, I just wanted to help men understand as well. So that's a little bit about me. Enough about me. Here's what we're going to be talking about today. It's the new Nice Guideline that's just come out last week. So what I'm going to do is I'm going to have a really quick run through of it with you. I'm going to give you a couple of highlights, a couple of criticisms of it. And then there'll be a chance for you to ask some questions at the end. Now, this hasn't been reviewed since 2015. And when they were going to review it and they put out the consultation, I think you'll probably remember there was a big kerfuffle about one thing in particular, which was that they seemed to be suggesting that CBT rather than HRT was the suggested treatment for people if they were experiencing depression. You'll be glad to know that's been changed back. So that's great. They listened to that. I'm going to run through telling you what's new and what's not. And then, as I said, we're going to give a little bit of guidance of what isn't ideal in it and what's great in it. So when you want to look at it, as you can see, this is the place to find it. But if you literally just put Nice Guideline or Nice Guidance on menopause into Google, it's going to come up. And it's going to come up with the most recent document, which is this one. And how it is, there's this page here. It's a lot more comprehensive than the old one. Then they've got tools and resources, information, public evidence and history. You're not going to use all these tabs, but they're all there if you wanted to have a poke around. So if we were to go into the actual guidance, which is, we would be pressing this next button here. I've got it as a new tab. This is the actual guidance. This is what I'm going to run through with you. And the first thing that it talks about is individualized care. Now, all the way through, what it does is it explains what was in the old guidance and what's in the new guidance, which is really helpful, actually. So all of this has been slightly amended, which is, it's not massively changed, but it's slightly amended. And what it's doing all the way through, basically, there is an emphasis on shared decision-making and information for the public, which is really great, obviously. It's got a bit of explanation that's not changed about the symptoms. All of this is unchanged. And then here we've got the bit that was controversial, but they've dialed it back a bit about the psychological support, saying if needed, refer them to psychology, whereas before it was basically saying give them CBT instead of menopause. But this bit here is about early menopause specifically, and there is a bit of a split between early menopause, premature menopause, all the way through, and general menopause. So this bit here about how it's diagnosed hasn't changed at all, but this bit here is new. So this bit here about how potentially people from some ethnic minority backgrounds and some medical conditions might experience menopause at a younger age. That was never in there before. That I think is really important for GPs to understand. This about how to test and what not to test and what to test, all of that's not new. That's all unchanged. And now we've got this bit here, which is new. Discussing management options with people aged 40 or older. Now, it's really interesting, actually, because they've seemed to have done a bit more of a younger split now. So they used to basically say, I'll show you up here. What they used to do is this split where we've got up here, where they said 45 and over, and then they'd split it 40 to 45 and under 40. Here, a lot of this management now just talks about 40 and over, which is new. Obviously, it's something to discuss with the person. That's great. We do want people to be discussing things with us, so we're making informed decisions. Now, when it talks here about HRT, and this is new, I'll mention this at the end as well, but there is a bit of a criticism here that although it's talking here about different types of HRT, etc., what it doesn't do really, it kind of mentions here transdermal versus oral. And it kind of mentions here types of estrogen and progesterone or progestins. What it doesn't do is it doesn't actually split out, and this is an issue for later on when we're talking about risk and benefit, different risks associated with different treatments. So there's oral HRTs and the older, more synthetic forms generally don't have the same risk benefit analysis as the newer, the body identical, which are generally preferable to use. And those are the ones that there is a bit of an omission. And I'll talk to you a bit about what the British Menopause Society had to say, because it actually is quite important that they haven't made that definition, and it's a bit of an oversight in all of our opinions. Also, it talks here about tailoring information about benefits and risks to do with the age, individual circumstances, etc. Obviously very important. And then there's some guidance as well. And then again, this is new, talking about if they choose to take it, explaining how long they can take it, reviewing it, and explaining what might happen if they stop taking it. There's a bit more about that later as well. So CBT, so this is the new bit about CBT, but this is what they've dialed back because of the hefty criticism they rightfully got. And so now it's talking about it as a possible management option, taking into account the person's preferences and needs. So this is much dialed back from what they'd originally said they were going to say. So this is saying it's a possible option. It's not saying do this instead of HRT, which was what we had as the big issue with. And obviously, this means that someone would have to be referred into a different service, which we know that can be difficult in the NHS. But this is good because this means people should be less likely to get palmed off with something instead of HRT. I've got a bit here about complementary therapies. This is unchanged from 2015. Basically, what it's mostly saying is there's lots of stuff that we don't really know, or that, you know, you can't guarantee what's in it. So managing symptoms in people aged 40 or over. Here we're talking about vasomotor symptoms, so that's hot flashes, night sweats. There's a little bit new here about CBT as an option. The rest of it's unchanged. Now there's this great new bit here that I am really happy to see in here. None of this was in here before, and this is so, so, so important. So, genitourinary syndrome of menopause. So this can be massively, massively impactful, both in terms of things like thinking you've got a UTI, and in terms of vaginal and vulval issues. And it splits it up into people with no history of breast cancer and people with history of breast cancer, which is also really important. So in people with no history of breast cancer, all this is new, and it's basically talking about the vaginal estrogen. It's talking about how rare side effects are, how rare issues are, how it doesn't get into the bloodstream. It's talking about shared decision-making about the type of vaginal estrogen used. It's talking about non-hormonal moisturizers and lubricants. It's talking about progesterone, which is, God, I'm having a menopausal moment. I'm even bloody on it. Someone help me out here. What's it called? Intrarosa. So that's great as well, because obviously that's not so much talked about normally. This is great because it really strengthens the argument for that as well. But what it's also important for is that some NHS formularies don't even have it on there at the moment. So this can help people try and push for that. It's also got this additional oral treatment that's mentioned. And then it's also referring people to managing urinary incontinence and pelvic organ prolapse in women as well, because sometimes we've got a bit of a crossover there as well. And then it mentions the UTIs here. What I actually am quite frustrated because the NICE guidelines on recurrent UTIs doesn't actually mention using estrogen, which I've criticised in the past. However, at least it is mentioning it here. So there's a bit of a circle needs finishing there, but that's great. So I'm super happy with all this because none of this was in here before, and it's really important. It could be absolute game changer for all of you. And even if you're on systemic HRT, you might need some vaginal local estrogen and moisturizers as well. And then this is super, super important. People with a personal history of breast cancer. So this is talking about offering moisturizers and lube to people with genitourinary syndrome of menopause who have a history of breast cancer. It's also talking about considering vaginal estrogen, which is super important. It does say it's an off-label use. However, that's still, none of this was here before. So this is really giving strength and confidence, hopefully, to GPs as well, that people can be prescribed this. Mentions specifically people with aromatase inhibitors, so it's going into some more detail here. And then it talks about treating each person differently here because different breast cancers are going to have different risk profiles. But it also, it says it's unknown whether it affects the risk. There has been some studies on this actually, and the reason it's unknown is because no one's ever studied it. What they have studied though is people who've had breast cancer and used vaginal estrogen, there hasn't been any additional recurrence. So although they haven't specifically studied it, they can draw inferences from other studies. And also, as we said before, the vaginal estrogen is absorbed locally, and it's so minimal that basically an entire year of vaginal estrogen is still less than 1 pump of the stuff we put on our skin. So again, giving people confidence who have genitourinary syndrome of menopause and have had breast cancer that they can use vaginal estrogen. And again, talking about people with this other personal history here and splitting them out into positive and negative. Okay, so laser treatment, this is new, saying no, don't use it unless it's part of a randomized control trial. And then we get onto the depressive symptoms, which they've expanded. So we've got they're considering HRT, but we expand it out here from what it used to say. So talk about considering CBT, but it's also talking about it in addition to other options or when other options aren't working or are contraindicated. What it used to say is it used to basically say, in layman's terms, if someone never had any history of depression and they got depression during perimenopause or menopause, give them the HRT. If they had a history of depression, you might want to give them antidepressants. Again, here, there's not any mention of antidepressants, but just talk about the CBT. Apart from here, this bit here, which therefore refers back to using antidepressants potentially. So this is expanded and it's much better than in the original draft, and hopefully should be quite helpful because it's trying to say kind of fit it to an individual. Got a new bit here on sleep because obviously we all have this issue with sleep. Again, it's talking about menopause-specific CBT as an option in addition to or instead of if someone doesn't want to. So again, it's not saying give it instead of HRT. What it's saying is if you're doing all the other stuff and they're still having issues, you could do it. Or if you can't do any of the HRT stuff, you can do it. This bit here on altered sexual function, this is unchanged from 2015. It just simply says consider testosterone supplementation for people with low sexual desire associated with menopause if HRT alone is not effective. So again, what that's normally taken to mean is put someone on HRT, so the estrogen and the progesterone, let them try it for about 3 to 6 months. Then if they're still having the issues, then you can start considering the testosterone. Obviously, that's a big issue in itself because most GPs themselves won't initiate prescribing of that or aren't allowed to by their local primary care board. This bit here is unchanged about considering the full medical history. This bit here is unchanged about type 2 diabetes. This bit here about the venous thromboembolism, unchanged. This bit here is new about coronary heart disease or stroke. Now, I kind of think this is quite helpful in that it isn't saying it's a hard no. And I think a lot of people in the past who've had a stroke or heart disease have been just told it's a hard no. So again, this is giving people who may want to have a different discussion more options here. Then we've got breast cancer, which has been amended ever so slightly and pushing people towards people with expertise in menopause. And then we've got ovarian cancer. I'm going to speak a little bit more about ovarian cancer at the end. So I'm not going to say anything here. And then we've got this section here about a medical menopause. So they've amended the 2015 guidelines here, and they've really missed a trick in this, and they have throughout the whole document. So basically, throughout the whole document, the feedback that's been given by many, many medical professionals, I completely agree with, is that there's a gap, a massive gap in what they're saying in terms of inclusion and support of people who have early menopause and people who have surgical menopause. Surgical menopause is absolutely the hardest menopause. So if you have a hysterectomy where your ovaries are taken out, that is the hardest menopause, because one day it's just gone. And that's really tough on the body and on the emotions and the mind and hormones, because you've just gone, they're gone. If you have a medical menopause that's, say, as a result of your hormones being switched off by breast cancer treatment or something, then that is nearly as hard as a hysterectomy in terms of absolute hormones gone, but not quite as hard. So it is really, really a shame. They've missed so much they could have said here, just to emphasize that, but also talk about how if you have a medical or surgical treatment leading to menopause, or if you have early menopause, the impact on the body is so much different. I'll mention that again in a moment. We've got this new section here about people who are trans, who still have menopause symptoms. So that's really good to see something in there about that. It's very important that they don't get left out. And then here we've got the effects on specific health outcomes section. And then it's a bit random because they've split it into 40 and 45. So they say 40 here and then they say 45. Anyway, I'll run through this quickly. They say it's not going to alter your life expectancy if you start taking it over 45. They talk about combined HRT for those of us with a uterus. Again, all this is new, talking about different options. The best one, balancing benefits and risk, all that's new. And then they've got this massive table here. And this is basically showing the different health outcomes. So we've got the all-cause mortality, we've got the breast cancer risk. I'll mention a little bit more about this in a moment. We've got endometrial cancer. So all this is new, talking about reducing the risk. We've got the ovarian risk here. I'm going to mention a little bit about this later because it's not quite right. We've got the coronary heart disease here, in confirming no increased risk. We've got dementia. All not super happy about this. Basically, it's saying if you start it over 65, there may be a risk of dementia. What you'll notice here, there's nothing about how it might prevent dementia, which I think that's fair, but it feels a bit wrong that it's completely blank. I think this could be better as well. Osteoporosis, they've not changed any of that. Basically saying that there is evidence of a reduced risk of fracture. I know it's a huge issue for us as women. Actually, one of the biggest things we can do, sorry, I keep moving up and down. You're probably going like, what's she doing? One of the most powerful things that we can do as women to reduce our risk of osteoporosis and to reduce our risk of losing muscle mass and strength is weight training. Please, please just understand quite how much that difference can be. It's huge, absolutely massive. Stroke, so this is new. It's talking about unlikely to increase risk, but then it's talking about this oral increase in risk. So again, this needs to be looked at on a very individual basis because there can be some ethnic differences as well. Type 2 diabetes, no increased risk, and no adverse effect. Interesting that they've gone for the risk, not the benefits here, because actually there is some data to show that the risk of type 2 diabetes is actually reduced if people can be supported by HRT to improve all their other symptoms, their weight, their movement, etc. And here we have the thromboembolism, that risk is not increased for transdermal, but is with oral. That's unchanged. Again, this was one of the things that it could have done with being a bit more explicit, really, saying there were different types of HRT that have different risks. So then they split it out here into the estrogen-only type as well, because for people who've had a total hysterectomy, so a hysterectomy taking out their ovaries as well, they're not having the progesterone. So they've got different risk profiles. So basically, we've got the same table again with all the different sections, but this is with just the estrogen, no progesterone, because obviously those people aren't taking any progesterone. Then we've got a section on cardiovascular disease where they're saying don't use it as a prevention tool. So if someone's got a risk of it, don't say, oh, here's some HRT and this will reduce your risk, because that's not what it does. Then we've got, again, a section here on dementia saying, again, yeah, you could take it, but don't use it as a prevention tool. That's not what it's for. And then we've got the section here on people in early menopause. And what this section here means is basically what they're saying is that people who are under 40 who take HRT have different benefits, bigger benefits, than people who are over 45 who take HRT. And that the people aged 40 and 44 to 44, well, their benefits are somewhere in the middle. Well, that stands to reason, basically. Now we talk here, going back again to the guidelines that haven't been changed about diagnosing premature ovarian insufficiency in people under 40 and the management of it. I feel like this probably could have done with strengthening a bit, to be honest. But what's really important is here, which hopefully everybody knows, is that it's really important to start some treatment of giving people their hormones back if they've lost them under 40. And what's a bit frustrating is that although they say that there's not these other bits throughout the whole thing that are really trying to emphasize this, which would have been good. Then we've got a bit about starting and stopping. So this is all new. What's nice is here we've got this bit about potentially seeking advice from someone with specialist knowledge of a condition. So say someone had rheumatoid arthritis, that you might want to have a conversation that took everything into account to see if there was something that would work better or something that could be affected. Use the lowest effective dose. Well, we've had lots of talk about that in the media recently. And that's really the case for everything, isn't it? Use the lowest effective dose to get what you want. And then this is unchanged about the vaginal bleeding. Then we've got a bit about stopping HRT. This is unchanged. And then there's this bit here just saying stop HRT in people who've diagnosed with breast cancer. It doesn't say it here, but somewhere else in this, I'm pretty sure it says it somewhere else in this. It definitely says it in the British Menopause Society recent thing, saying, but basically it said you don't need to stop. I would have liked to have seen it more in here. In fact, it was in the British Menopause Society thing. Reviewing treatment, it's recommending through every 3 months, at 3 months and then annually, unless something changing. And this is unchanged. Again, here, this is unchanged. If these treatments aren't improving the symptoms or you're having ongoing side effects, send them to a menopause specialist. That's unchanged. We know there's issues with that. No, it's hard to get. And then that's just the terms. So we've done that now. So now I'm going to show you a couple of other helpful bits. So if you saw along the top, there was this bit here, information for the public. So this is helpful to see as well. So basically, this is their like statement that isn't for healthcare professionals, it's for the general public. And they're saying this, which I think is helpful, that menopause is identified by healthcare professionals as early as possible, so you get the support you need, and that they discuss all the treatment options with you, explaining the benefits and risks, so you can work out together what might suit you and best balance treating your symptoms with any risks. They say risks so many bloody times in this document, it's insane. Taking into account your age, medical history, needs and preferences. So this is super important, because obviously this is really pushing to say, look, have a conversation with people. Doctors discuss things with the patients, and let's not leave people hanging, and let's help them make a shared decision. So that's brilliant. And we've got making decisions together, and we've got these kind of discussion prompts again, that's super important. And I think it's really great to have that in there, so if necessary you can slap someone around the head with it. And then it's got these, where can you find out more? Very disappointed it doesn't have me in there, ha ha. Anyway, so that's that. Now I'm going to show you a couple of other really useful documents. So we've got this HRT and the likelihood of some medical conditions that's come as like an accessory download. This is quite nice because it's a bit of a visual, but some of it's not bloody right. Been quite a few doctors who've come on and said, no, this isn't okay. And the British Menopause Society has as well. So basically, this document is really nice in the way that it explains cumulative risk of things, the endometrial cancer here, we've got the ovarian cancer here, and it's nice because it puts it into a really nice visual of the actual risk. Heart disease, dementia, osteoporosis, stroke. And then it splits it again. All those first ones were on people with estrogen and progesterone. These are ones with estrogen only. So these are for the people who've had hysterectomies. And then it's all the same again for them. So I think that's a great document, with the caveat that some of it's not quite right. And I'll talk to you about that again in a moment when I get to the British Menopause Society response. We've also got this super document, specific document that never existed before, that's a specific thing for the genitourinary syndrome symptoms. And it breaks it up by, do they have a history of breast cancer or don't they have a history of breast cancer? And it's literally a walkthrough of what you can do leading to vaginal estrogen. So basically, this is just literally a pictorial of what I was saying to you when I was looking in the actual main guidance document. If you've not got a history of breast cancer, offer and discuss vaginal estrogen. If you've got a history of breast cancer, start off with non-hormonal moisturizers and lubricants. And then if that doesn't work, consider vaginal estrogen. This is erring on the side of caution, even though we know it stays local and doesn't go systemic. They've got to basically err on the side of caution just because they're very, very, very cautious. But I think this is super important, because this is one of the things that can affect women so much in terms of painful sex, bladder urgency. There's so many symptoms and it can be really, really disruptive to life. So I'm really happy to see that in there. We've also got this section here that's in the separate NICE guidance, but is mentioned a lot in the menopause guidance. So I'm just going to show you it about the shared decision making, just so you see the definition of what it means. It's basically saying that it wants you to work together with the healthcare professional to reach the decision about the care. So you're going to be informed and you're going to have a discussion and you're going to have informed consent. So I think that's really important, that they are really trying to say, let's do this. And that can be sometimes really helpful for you if you need to, if you're struggling with a GP or you want to see a different GP. I think it could be really helpful to know that's in there. Now I'm going to quickly tell you what the British Menopause Society said, but not the whole of it. But I'm just going to draw your attention to a couple of things. So the British Menopause Society said it was really happy about some of the stuff in there. That was great. But there was two things it was really, really concerned about. Well, there was actually three, sorry. So it was really not happy about the fact that it wasn't enough about the impact of early menopause on bone, cardiovascular and cognitive health. I completely agree with that. There's just not enough in there about it. You'll notice there was hardly anything in there. And if someone has an early menopause or premature ovarian insufficiency, their risks for cardiovascular disease, osteoporosis, sarcopenia, and potentially for brain health are massively increased. We know this over longitudinal studies. So it's a real missed opportunity to have that in there. And it's not strong enough in there, they felt, and I agree, about saying, if you've got early menopause, we really need you to be taking HRT, if not forever, just until the point of the average age of menopause to mitigate these risks. Also, it's pointing out, the British Menopause Society is pointing out, that the data on the breast cancer risk is not right. It's hugely important, this. So the Lancet did a study, and this study they've used wrongly. And this is the issue. So the British Menopause Society is saying no, they're saying there's more, the Nice Guidelines are saying there's more risk than the British Menopause Society thinks there is. It thinks they've cherry-picked the evidence in the wrong way. And again, what it's saying as well is that it was looking at people on different forms of HRT and different forms of progesterone, and that does make a difference. As you can see down here, synthetic. And that's the difference. It depends on what you're on as to what the risk is, and that the British Menopause Society hasn't taken any of that into account. Also, ovarian cancer. It's not correct, because there was a randomized controlled trial here that showed there wasn't a significant increase in risk. And then the breast cancer mortality. This is, again, referring back to some Lancet data and saying that they've used the wrong evidence. So I know that Louise Newson was very unhappy about that as well. Louise Newson was also very unhappy about the fact that there wasn't enough differential between the older, more synthetic forms and the newer body identical forms. I think that's all very fair. Something that nobody else has had a bit of a moan about, that I'm going to have a bit of a moan about, is I'm really, really unhappy about the fact that it's still only got one reference to testosterone, and that was in relation to the off-label use for low libido. Now, I think that obviously we know that's very, very controversial, but there's a mounting body of evidence around there. I do think that although they're very risk averse and they're very, they don't want to be saying, yeah, it's okay until there's, absolutely incontrovertible proof. I think it's a real shame that they didn't put more in there around how there was some suggestion, and that it does appear to be the case that it can help with things like muscle and bone aches, cognition, mood, etc. So personally, I think that's really disappointing. Other than that, I think that was all I was going to say. You'll see it made some headlines like this one here, that everyone was really happy to see that it had changed, that HRT was the first line treatment rather than CBT. So this is from The Guardian last week. I think done in everything that I wanted to say to you now. So what I'm going to do is I'm just going to show you how you can stay in touch with me if you're not already following me and you wanted any more information. And then I'm going to stop the recording and you can ask any questions you want. So as I said, I'm 𝐧𝐢𝐤𝐤𝐤𝐬 Woods. Here's my main Facebook page. Feel free to follow me on there. I share all sorts of stuff on there about menopause and about more general women's health, and occasional stuff about myself, of course, because it's my personal page. I've also got this Facebook group here, Your Best Midlife. This is a private group. Please feel free to come join this as well. I've also got my Instagram if you want to follow on there. And if you are more a LinkedIn person, please come follow or connect with me on LinkedIn. 𝐧𝐢𝐤𝐤𝐤𝐬 Woods on there as well. I am now going to stop screen share, and I'm going to stop the recording, and then we can go on to Q&A.